can start.
Good morning to everyone and welcome to MonteHeart today. Today our host is Dr. Claudio Laudani, who is a cardiologist based in Catania now. He's been in Jacksonville for the past year and is very experienced in the management of patients with ischemic heart disease. Today's topic is on completeness, timing, and guidance of PCI for MI and multivessel disease. And Claudio, thank you for joining us today.
Actually, thank you for having me. I'm really honored to be here today and speak about this really complex topic, actually. So I would like to start with some introduction on the topic because we know that patients with acute myocardial infarction and multivessel disease actually have a higher rate of all-cause mortality, even in the short term. So having a twofold higher risk of mortality at 30 days. But therefore, there was a big question here. So if patients with multivessel disease have higher mortality, does it make sense to treat actually the multivessel disease by performing complete revascularization? And if we look at the data from the PREMI trial, being one of the first trial on this topic, we see that actually performing complete revascularization reduces long-term outcomes, 30 days outcomes by 65%. And so we have several other trials that aim to compare complete revascularization compared with culprit only or infravelated artery only revascularization. And most of them show a significant reduction in adverse outcomes on the long-term follow-up. But still there were some lingering questions regarding the guidance. So some of them use imaging guidance, some of them use functional guidance. And also regarding the timing, so it was better at the index or staged procedure. And we had several other trials that gave basically mixed results. So we don't really know the answer for that. And then we have several lingering questions on this topic because we still say that complete revascularization may improve outcome, but we're not sure about that. Then we say that if complete revascularization is sought, we still don't know if it should be guided by angiography or by a functional assessment, and also whether if the optimal timing is during the index PCI or at a staged procedure, and even at which time of that staged procedure. So against this background, we decided to perform this network meta-analysis, and we basically include trials with random allocation of stable AMI patients to either two of these revascularization strategies. So either only revascularization, angiography-guided immediate or staged revascularization, and functional-guided immediate or staged revascularization. The primary and co-primary outcomes were myocardial infarction and cardiac death, while the secondary outcomes were all-cause mortality, definite or probable stent thrombosis, and revascularization, ischemia-driven revascularization, trial-defined MACE, and the periprocedural outcomes, including stroke, acute kidney injury, and major bleedings during the procedure. Regarding the analysis, we performed the analysis both with the frequentist and the Bayesian methodologies. The primary analysis include a 5-node network that included all the revascularization strategies aforementioned, but we also performed 3-node networks that compare era-only versus staged complete revascularization and index complete revascularization to achieve statistical power and also to answer basically a different question. So regarding the timing of the revascularization, we pulled the events as hazard ratios, and we used the Sucro analysis to evaluate which treatment was actually the one with the higher probability of ranking first. And we also assessed inconsistency by not splitting analysis and performed other secondary analysis to assess the source of heterogeneity, which included subgroup analysis and meta-regression analysis to evaluate the influence of diabetes, free vessel disease, and the year of publication on overall treatment effect estimates. So regarding the results, we started from almost 6,000 records in the literature and ended up including 14 studies. Of these, basically we have half of them, 7, that compare different revascularization strategies with era-only revascularization, and the other half that compare different strategies one to another. And regarding the quality of trials, most of them were classified as some concerns. This was mostly due to the design, because most of them were open label, which I mean, it makes sense because this trial it will be unethical to perform a sham procedure on a STEMI patients, and also it will be pretty much unfeasible to perform a sham procedure during a STEMI call. And if we look at the baseline characteristic, we can see that patients were mostly around 65 years old. Most of them were male. All the trials, apart four, included only STEMI patients, which are, of course, the major population of this analysis. Diabetes was around 50% of the patient. The free vessel disease was present in 30% of patients, and only a minority of patients presented with chronic kidney disease, apart in the FIRE trial that since it involved mostly elder patients, the percentages of patients with CKD was higher. And if we look at the structure of the network, we can see that era-only vascularization was the procedure used most often, then followed by angiography-guided staged complete revascularization, then angiography-guided complete during the index procedure, and then the functional guided staged and index complete revascularization. Similarly, if we look at the free node analysis, we're going to see that era-only revascularization was the more common, then followed by the staged complete revascularization, and then immediate complete revascularization. But let's focus a little bit on the 5-node analysis that is the main analysis of this study. If we look at the two co-primary endpoints, we're going to see that index revascularization, either by angiography or functional guided, actually reduced the myocardial infarction complete with era-only revascularization, while there were no significant difference in cardiac death. But when we repeated the analysis in the Bayesian frameworks, that usually is more conservative, we found that only angiography-guided index complete revascularization reduced myocardial infarction compared to era only, while cardiac death was still not significantly reduced by any procedure. If we look at the complete comparison, we see that angiography-guided index complete revascularization reduced myocardial infarction also compared to the staged procedure, both angiography and functionally guided, well, there were no difference in cardiac death. And if we look at all other outcomes, we're going to see that there was a sign for reduction in all-cause mortality by functional guided index complete revascularization, and also an increase in stent thrombosis for functional guided staged complete revascularization. But most importantly, we saw a reduction in any revascularization, in ischemia-driven revascularization by complete revascularization by any way, so any index or staged and any guidance used compared with era only. But when we look at the pooled analysis, so at MACE, we're going to see that only index revascularization reduced by either angiography or functional guidance reduced the outcomes compared with era only revascularization. When we look at the Bayesian analysis, though, that basically was to confirm the results, we see that the index vascularization, as we say, was the only one reducing myocardial infarction compared to era-only revascularization, and that only index revascularization reduced any revascularization compared with era-only revascularization. So basically, it was not confirmative. Also regarding the previously reported increase in stent thrombosis for functional guided staged revascularization. And if we look at the ranking, we see that index revascularization actually ranked first for almost all the endpoints, either for functional guided, that seems to be the one to prefer, or angiography guided, but it was always the index revascularization. However, there's something that we found in our analysis, and I have to do an explanation on the statistical part because I don't know how many of the attendings here are confident in evaluating network meta-analysis. So the topic is inconsistency. When we evaluate the results of a network meta-analysis, we pull the results of two different comparisons between two strategies. That is the direct comparison, being the one evaluating the results by a trial. So there is a trial that compares treatment A and treatment C, and that is direct comparison. But we also have an indirect comparison that comes from the comparison between A and C being evaluated evaluated through an indirect comparison between A and B and C, and then doing the difference in this indirect way. And the direct and indirect comparison should be the same. In case the direct and indirect comparison are not the same, it means that basically there's something usually related to the trial design or the population included that cannot make the results reliable. Most importantly is usually because of baseline characteristics that differ too much across the trials. And this is actually what we found, because as we said, we found a reduction in cardiac death, but actually we found also some inconsistency in these results, so that it basically makes the results unreliable for this endpoint. And similarly, we found a similar inconsistency for any revascularization, particularly when evaluated the index complete revascularization compared with ERA only and with angio-guided complete revascularization at the stage time. And so let's focus a little bit on the free node networks, because maybe it was because of the inclusion of too many trials and too many designs that lead to the presence of inconsistency. If we look at the co-primary endpoints, we see that index complete revascularization reduced myocardial infarction compared with both ERA only and staged complete revascularization. And also, it appears to reduce cardiac death compared with ERA only revascularization. But when we repeat the analysis in the Bayesian frameworks, only index complete revascularization compared with ERA only was still significant for reduction in myocardial infarction, and the results for cardiac death were no longer significant. Once again, if we look at the complete comparison, we're gonna find also a reduction in myocardial infarction for staged complete revascularization, and for all-cause mortality with index compared with ERA-only revascularization. And regarding the vascularization strategies, we're gonna find a reduction in any revascularization, ischemia during revascularization, and MACE compared with ERA only, but also a reduction in MACE with index compared with staged complete revascularization. But when we replicated with the Bayesian analysis, the reduction in myocardial infarction was still significant, but the reduction for revascularization and MACE was significant only for index complete revascularization compared with ERA only. So no main differences with stage complete revascularization. And a ranking of treatments, once again, index complete revascularization was ranked first for all the endpoints included. And if we look at the inconsistency, because we said that we did it also to try to overcome the limitation of including too many design and comparing two different strategies. And we still found some inconsistency regarding revascularization for index complete revascularization and staged compared with ERA only, and also between index and staged complete revascularization. Regarding the secondary analysis, there were no differences in peri-procedural outcomes in both 5 and 3 node analysis, and we found no significant differences for meta-regression, but we found an introduction of heterogeneity for myocardial infarction regarding that was introduced mostly by the FRAME AMI trial. So now I think we're a bit confused, so I want to focus my discussion on 3 main points, which are the effects of complete revascularization on myocardial infarction, the effects on cardiac death, and the effects on future revascularization, because as we said, are the one where we found some differences, but we also found some inconsistency. So regarding myocardial infarction, we found that complete revascularization, especially at the time of index PCI, reduced myocardial infarction compared with ERA-only revascularization. And this was independently of the type of guidance. Regarding the free node analysis, the index PCI reduced myocardial infarction by 45% compared to staged complete revascularization. And on one end, we could say that there's this sub-analysis from the culprit trial that could make sense, could explain these results, because basically they looked at the characteristic of non-culprit lesion, and they found out that 70% of this lesion, either obstructive or non-obstructive, were actually thin cap fibroateroma. So treating this lesion that are prone to rupture and erosion could prevent a myocardial infarction because of that. Then regarding the stage procedure, we must say that even if we could speculate that the treatment of this lesion may prevent myocardial infarction in the time between the index and the staged procedure, this is mostly related to periprocedural myocardial infarction. That was something that was included in almost all trials. So we can safely say that we prevent myocardial infarction compared with era-only revascularization. But for the different with stage revascularization, we should be cautious. Then, with regards with cardiac mortality, we saw that complete revascularization at the time of index PCI reduced cardiac death by 32% compared to era-only revascularization. But as we said, this result was fragile and inconsistent across analysis. So on one hand, we could just end here the discussion because thanks to this analysis published on JAMA Internal Medicine, we know that having a second myocardial infarction doesn't mean having a higher risk of death nowadays in current PCI era because we have the STEMI network, the procedures are done way better compared to 20 years ago. So new myocardial infarction is not a death sentence anymore. However, in this individual patient data meta-analysis published on Lancet, the authors found a 24% reduction in cardiac mortality when performing complete revascularization rather than era-only revascularization. And interestingly, these results was consistent independently of the revascularization strategy, so either angiography or physiologically guided. So we can conclude that complete revascularization reduces mortality, although we cannot say if it is related to index or stage revascularization. And finally, we must discuss about future revascularization because we saw that index PCI with complete revascularization, our stage procedure, reduced repeat revascularization by 50 to 65% compared to era-only revascularization. However, the results was once again inconsistent across analysis. So this, as I said, can make sense because basically you treat lesion that could destabilize later, so you reduce ischemia, but we must say that the main reason for the inconsistency across trial is more likely related to the design of the studies because as being open label, all treatment physicians that were involved in the follow-up were aware of the treatment. So basically, if I am a cardiologist and I'm looking at a patient that said that has a typical angina, and I know that he was not completely revascularized, then I will refer that patient more often to the Cath lab compared to a patient that I know has been randomized to complete revascularization. And so I will more likely consider that chest pain as either atypical or not anginal, and not refer that patient to the Cath lab. So in conclusion, we can say that in patients with acute myocardial infarction undergoing PCI and that are not in cardiogenic shock, complete revascularization improves long-term outcomes independently of the type of guidance, so either angiography or functional. The complete revascularization at the time of index PCI seems to achieve better outcomes compared to a stage procedure, but we cannot derive definitive conclusion on this. And although evidence will try to use the functional rather than angiographic guidance, such evidence is highly inconsistent. And with this, I conclude my presentation, and thanks for your attention.
Thanks, Claudio. This was a brilliant talk, and I think it was very clear. You investigated all these points. I have several questions for you. Maybe the first one, I would like to ask you if you can please clarify when you talk about immediate complete revascularization, is that during the index procedure, index hospitalization, within a time frame? Can you please let us know what that means?
So it depends on the trial. Thanks for the question because it was something that I cannot clarify strictly in the presentation. So most of the trial are used during the index hospitalization. Some of them, but are just a minority of the trial included, used during the index procedure. But if I have to translate this into the real world, I will say that this is more likely not feasible because if you have a STEMI call at 2 or 3 a.m. and then you have to perform a complete revascularization with all non-calculable lesion, I mean, they will probably put also the patient at risk during the procedure. So I would rather say that it's safe to perform it in hospital during the index hospitalization, which is also what most of the trial actually did for ethical reasons.
Thank you. So you said clearly we need to complete the revasc in our patients. There's not enough evidence on either angio or functional guidance. Which trial would you design to answer all these open questions?
So this is a really interesting question. So if I had to design a trial, probably I will design a trial for index. I will design two different trials. One for the index revascularization, that I think is actually the most important one. So at complete revascularization at the index procedure, randomized to treat non-culprit lesion either by angiography or functional guidance. And this should be decided before the procedure. So I will not put like intermediate lesion, blah, blah, blah. I will put if they're angio-guided, then you decide depending on the obstruction. If it is functional guided, then even if they are intermediate lesion, you put an FFR and decide if it should undergo revascularization or not.
Thank you. Let's see if the others, they have some questions. Piero, do you have any comments?
Claudio, thanks. That's great work.
Thanks.
Really love your dedication to this. I'm looking a little bit into the future now. We have all this data. We have new technologies right now. There's OCT that can help us just understand a little bit better how the plaques look. Sometimes you can do OCT also without contrast. And there's whole intravascular technologies that can help us a little bit understand what kind of plaque we have in front of us. Do you envision in the future a situation where maybe we kind of have a pedigree of the coronary anatomy of a patient post-MI, and we try to identify the plaques that really can actually predict outcomes? Because, the dichotomy of, lesion being tight versus being at risk of MI, it's not always straightforward. So I'm just wondering if in the future you think some other studies might look into selection and guidance, like you said, for this revascularization with new technologies, hopefully, and most likely intravascular.
Yeah, thanks. This is also a very interesting question. I will say yes, because basically there is now mounting evidence, complete mounting year after year on the use of intravascular imaging to select the plaques to treat beforehand. We now have evidence even in the context of chronic coronary syndrome, even in the PREVENT trial, where we found a significant reduction in long-term outcomes when the plaques had characteristics derived from OCT or IVUS. So I will say that probably what I would like to see next, if that similar outcomes can be derived by using IVUS or OCT, even in this context. Although I know that that will be way more difficult. So probably I will say a staged procedure during the same hospitalization to assess the non-culprit plaques for evaluating the presence of characteristics that are related to long-term events.
Yes, and
Thanks. No, go ahead, Andrea.
Nice. I was just about to read, like we have a very similar questions to the one asked by Pier Pasquale. Juan Torrado is a last year fellow in cardiology here in Monte, is asking, just to complete the answer you just gave us, if there might be any inflammatory or biomarkers or OCT related features to guide revascularization. Do you think there is one or more tools that can help us in answering this question?
So regarding the inflammatory markers, the biomarkers, I will say that at the moment, no, because there is some evidence on CRP and interleukin-6, but they're more for the chronic and to evaluate the residual risk rather than the acute risk. Because in the acute phase, we have a surge of both C-reactive protein and interleukin-6, so it will be hard to find a serum biomarkers of inflammation specific to that moment, because the inflammation is going everywhere in all the plaques. Regarding the OCT analysis, I will say yes, because we already have fibroateroma that can be used to drive the vascularization, but there are several studies that are now showing that we can see the presence of plaques more prone to rupture, because there's OCT in certain plaques that can even evaluate the degree of macrophage infiltration. That is already a marker of inflammation of the plaques that has been used. And also the use of microvascular presence inside the plaque that can drive the selection of the plaques to treat in prevention.
Thank you.
Hi, it's Azim, Claudio. So I have a couple of comments and questions. I really like the analysis because it kind of also highlights maybe, some of the challenges of treating STEMI and some of our, I guess, confusion at times about what to do, right? I mean, the fact that angio-guided was, the best, and complete revascularization is the best compared to functional, just kind of, I think for the fellows, is a good reminder how the process during a STEMI and NSTEMI during ACS is very different to the patient with chronic stable coronary syndromes. And I think, everybody's highlighting the importance of other plaques that may not be stenotic or may not be as stenotic or may not be functionally significant, but could lead to an acute MI. And to me, that's kind of, reinforces a little bit, based on everything you guys have been saying, how the whole sort of enigma of vulnerable plaque is still an enigma. And potentially this analysis, again, highlights we have to figure it out, because to me, that's probably why we're getting this benefit from complete revascularization. The challenge I have with the data, besides the fact that these network meta-analyses, sometimes you did an amazing job to try and find the deficiencies of it and highlight them, but there's still, as you know, unmeasured deficiencies and that are within the analysis. I think we still have to use it to try and push ourselves to try and figure out the whole why there is this benefit, because we've seen it. But I guess my challenge is, these studies come over such a large period of time. There's so much variability, like Andrea said, in the timing of revascularization. But the other thing I think, you guys were highlighting that we can't ignore is how medical therapy is changing, right?
Mm-hmm.
And how, if you look at these studies, I mean, you started with PRAMI, right, was in this analysis. I mean, there was no even, there was no prasugrel or ticagrelor or high-dose statins are now, a reality. And I bet you there's going to be other therapies we use in the next coming years, that are also going to be impactful. I just don't want people to go away with the message that, oh, stents will fix everything, because stents have their own shortcomings. And we all know that stents placed in the setting of STEMI have higher rates of stent thrombosis. So I don't want the message to be we stent everything, but I think for me the message I take away is, we need to do complete revascularization, not necessarily during the same procedure, but during the same index hospitalization. We need to better understand how to identify and manage vulnerable plaques. And maybe in the future, we could be doing that even without permanent scaffolds, whether that be bioreabsorbable scaffolds or even drug-coated balloons. So I'm very interested to see how this field evolves, but I want to make sure we all take away the right messages.
Yeah, so thanks for the comment, and I absolutely agree with everything you said, because I often say that we put stents, but there a patient attached to the stent, so we can put the stents as good. Could be as good looking as we can, but you have to treat the patient completely. You have to manage with high intensity statins. You have to manage with the antiplatelets, also because if we look then in the chronic coronary syndrome, we saw that stents are not the answer. Basically, if we look at the ischemia trial, mostly medical management is what actually drives the results. I mean, stents are important for reducing the ongoing ischemia and preventing the long-term evolution of reducing left ventricular ejection fraction, but putting a lot of stents doesn't mean that you don't have to treat the patient.
Exactly. Great comment.
Hi, thank you for the great presentation. there's so much data. I feel like it's almost like the anti-platelets data. The more you have, the less you know what to do. So I was wondering, because angio is doing so good in the context of post MI non-complete lesion revascularization compared to physiology. Do you think there will be a role for full back pressure gradient in the future to refine a little bit better what lesions need to be treated?
So thanks for the comment. I must say that there are a lot of discussion regarding the use of any type of functional evaluation in the context of STEMI, because we know that FFR has not proven to be very, very reliable. On the other end, we have the FIRE trial that was actually very good in the complete revascularization context. And regarding the pullback gradient, the evidence is still lacking. I mean, we're still we still have to understand if we can use that in the chronic coronary syndrome, then facing in the context of STEMI, I'm not sure we're gonna find that. So if I have to select what I would expect in the future, and I will say that this applies both for the STEMI and also for the chronic coronary syndrome, is to use mixed catheter. So to use the catheters that can achieve both the functional evaluation before the procedure and then the use of IVUS or CT for optimization. That's what I think is the real future of the revascularization in both the acute and the chronic setting.
Thank you.
Claudio, maybe I'll ask another question. You mentioned the FIRE trial, which enrolled exclusively older people. I was wondering if you, in your sensitivity analysis, you found any difference either based on patient age or even if the ACS was a STEMI or an NSTEMI. Was there any difference based on that?
Thanks. So no, in our sensitivity analysis, we didn't find any influence of either age or the percentage of STEMI patient on the overall analysis. Although we must say that it was driven by STEMI patient rather than NSTEMI patient, because as we said, only 4 trials included also NSTEMI patients, and these 4 trials, one of these included 90% of STEMI. So the whole population is basically STEMI rather than NSTEMI.
Okay, excellent. So that's even easier to remember the main messages of this. Let's see if someone else, Gianmaria, Osama, do you have any questions for Claudio?
No, Andrea.
Can you guys hear me?
Yes, we can.
Hey, Claudio, thanks so much for this great talk. I just want to ask you one more thing about the timing for the revascularization. Do you have any kind of recommendation regarding the best timing for PCI? Sometimes the patient might be in a severe cardiogenic shock, and we feel that sometimes it's better to let the patient cool down, put them on Impala for maybe 24, 48 hours, take it out, and then once the patient is more stable, sometimes we prefer to do a stage PCI, perhaps even during a different hospitalization. However, in some other literature, it says that if the patient is in cardiogenic shock, it might be beneficial to open the other vessels. Do you have any thoughts or recommendations?
Okay, thanks for the question. Basically, we must say that the results of this analysis do not apply in patients with cardiogenic shock, because we only have one trial evaluating the effects on patients with cardiogenic shock, which is the culprit shock. And this trial actually showed that complete revascularization in this setting was a problem actually, because the patient had a worse outcome in this setting. So if you have a patient with cardiogenic shock and multivessel PCI, multivessel disease, you should aim to treat the culprit lesion and then refer the patient to the CV ICU, stabilize the patient, and then decide after that if it is worth to perform a complete revascularization. And in this setting, of course, it should be a staged procedure. More likely, I will say during the index hospitalization, but I cannot translate the results of my analysis to these patients because they were not enrolled in these trials.
Thank you.
Okay, any more questions from the... the audience, anyone who has any question left for Claudio? If not, I think, Claudio, we can maybe conclude here your talk.
Sorry, Andre. I just have one quick question.
Okay, yes, please, Taylor.
Great talk. I was wondering if there's anything in the literature or anything in your experience that would favor immediate revascularization or during at the time of the index procedure or hospitalization based on what is the culprit vessel versus what's is left to revascularize. Are you more likely to revascularize an LAD if someone came in with an RCA STEMI because it's the LAD and feel that it doesn't waiting might not be the best for that patient versus it's the opposite where it was the LAD was the culprit and then you just had to stage the RCA and you felt that you had time to wait on that.
Okay, thanks for the question. So I must say that there is no specific evidence on that because basically most of the patient enrolled that has LAD as a culprit lesion, but it was like 40% of the patient. All the other patient had between LCX or RCA. So I must say if we have to look at the data, I mean it is independently or where the culprit lesion is. You should still aim for the complete revascularization independently of that. Of course. Treating an LAD is probably more important because we know that 45% of the viable myocardium is dependent on the LAD. But I will say that the complete revascularization applies to any vessel in any setting.
Excellent. Thank you, Claudio. Any questions left? If not, I think we can conclude now. Claudio, thank you again for giving us this great lecture. Still, there are many questions open, so maybe when more evidence will be available, we will invite you again to give us an update on this. Thanks, Claudio.
Absolutely. Thanks for having me, actually, and enjoy your day. Bye.
Thank you. Bye.
Thanks, Claudio. Bye.